Hi there, my name is Regina Fink, and I'm a research nurse scientist at University of Colorado Hospital and an associate professor at the College of Nursing. I'm here today to talk with Dr. Stacy Fischer, who is a palliative care physician who I work with on an Apoyo con Cariño grant studying to improve palliative care for Latinos with advanced cancer. Today we're going to be talking about prognostication, and Stacy, I'm really glad that you're here with me today.
It's great to be here.
Why don't you tell me a little bit about yourself and how you got interested in palliative care and actually this topic?
Great. So I am a physician by training, and I did a internal medicine residency here at the University of Colorado. And during my chief residency year, I became interested in the topic. I was asked to give a grand rounds, and I started thinking about populations that I felt were marginalized. And that led me to looking at end-of-life care as a model for that. And once I finished that grand rounds, I was hooked. I said, this is what I want to do. I gave up an endocrinology fellowship, and the rest is history. The opportunity to work with an interdisciplinary team, nurses, chaplains, social workers, in a collaborative fashion, and focusing on what is really important in life has been an incredibly rewarding career.
Great. So how accurate do you think clinicians are in estimating survival?
Unfortunately, what we know is that clinicians are very inaccurate. We do have prognostic indices, and we can talk about those in a little while, where we can look as providers at a group of patients and say, with a very high degree of certainty, this percentage of patients will survive, this percentage of patients will die. However, when we're looking at any one patient, we are actually really inaccurate in predicting. And what we know from the literature is that we tend to overestimate survival, usually by a factor of 3 to 5. And that can be a real problem. When we're thinking about how important that topic is, you know, there are very important patient-centered reasons why it's important to prognosticate, because patients and their families need time to prepare.
Exactly.
Need time to make decisions.
Exactly.
And how to spend the time that they have in the best way possible. But there are also some really important aspects of prognostications at a health system level. For instance, what we know about palliative care providers is that specialty level providers, whether physician, nursing, social worker, or chaplains, are limited. It's a limited resource, and we have to be very selective of how we address the best patient needs in the best way possible. And part of that is through prognostication, deciding who has a very limited life expectancy, excuse me, and who can we expect to survive.
Okay.
Sorry.
That's okay. Tell me, do you think patients really want to know about their survival?
It's a great question. For a long time in medicine and healthcare in general, we believed that patients didn't want to know. When Elizabeth Kubler-Ross started doing her research on death and dying, she actually went to the nurses at the various wards and said, I'd like to talk to your patients that were dying. And at the time, she heard, well, we don't have any patients that are dying here. And what she found is that patients were marginalized to the end of the hall. But when you look at research from the 1950s, even though clinicians did not want to talk to their patients, and specifically, a lot of the literature is in the physician literature, where physicians said, no, patients can't know, they don't want to know, we shouldn't tell them. When they actually looked at patients and surveyed patients, patients overwhelmingly wanted to know the truth. But truth-telling is something that's evolved over the last 50 years, and before that really wasn't part of healthcare.
Well, how do you respond to a patient if they ask you, doctor, how long do I have left to live? Or many of us as nurses get asked that question. What do you think? How long do I have left? How should we be responding to the patient?
Great question. And it's one that I often will respond with a question. First, exploring maybe why they want to know that.
Mm-hmm.
It seems like a really important question. Is there something you're worried about? And exploring their fears and expectations as an initial step. And then I'm always, when patients are asking me about the time they may have, I'll always be careful to be transparent about the limitations, that we don't do a great job at prognosticating, and then I will often answer with some kind of range. I think time is very limited. That's my warning shot. It may be hours to days. It may be days to weeks. It may be weeks to months.
Giving a range.
Always give a range. And when I think that a month might be optimistic, or 2 months, I'll say limited months, limited weeks, to try to understand where they're falling in my estimation in that range.
Mm-hmm.
Again, it's to help people prepare and understand the time that they have so that they can make the best decisions possible for themselves.
Which is really important. I think patients really want to be able to make some plans. So you developed the caring criteria, and for our students, to let you know, we have a slide deck, PowerPoint presentation that Stacy has developed that talks about the caring criteria. That's available. And I've also included her article from 2006, I think.
That's right.
And so why did you develop the caring criteria, and tell us how it works?
Sure. So the caring criteria is a prognostic index, and we were doing a study where we were doing an educational intervention trying to improve palliative care knowledge and attitudes and behaviors for medical residents. And we wanted to look at their practice patterns before the educational intervention and after. And part of it is that we were going to look at all the charts of all the patients they cared for in that time period. That would be a lot of charts to review. Mm-hmm. So we developed the caring criteria to say, well, which patients, can we identify the patients that would most benefit from a palliative approach? We know someone coming in for a cellulitis that's kind of self-limiting and needs a couple days of IV antibiotics before going home. They probably don't need to spend a lot of time discussing their goals of care. However, someone that has come in for their third admission for COPD exacerbation, maybe that's someone that we should take a little extra time with mm-hmm. and try to understand what their goals and values are. So that's the why we developed the caring criteria. We identified some important aspects that we thought would help identify the patients that would benefit from the palliative approach. And when we went back to do those chart reviews, we found something somewhat unexpected, which was that most of the patients who had met one or more of these criteria had a very high mortality rate. At the VA, within their charting medical record, electronic medical record, you would get an alert, this patient has died, would you like to continue? And it seemed like we were getting that alert over and over again. And so we did another side project where we looked at the predictability of the caring criteria for 1 year mortality, and then we decided to review another 400 charts to validate that mm-hmm. caring criteria. Mm-hmm. So, how it works is pretty simple. In the slides, there is a slide about e-prognosis. I'll show you that right here. Mm-hmm. E-prognosis is a website developed by the University of California, San Francisco, and it contains many prognostic indices. If you look at the bubble view, you can select the Fisher 1 year caring index, and we can go through a patient.
That sounds great.
Okay. So, Regina, how old is your patient?
66.
Okay, so we're going to select 66 to 75 years of age. Does your patient have a primary diagnosis of cancer?
Yes.
Okay. How many times has your patient been admitted to the hospital for cancer or other chronic illness in the past year?
3.
Okay. So we'll say 2 or more. Is your patient a resident in a nursing home?
No.
Has your patient been admitted to the ICU with multi-organ failure during this hospitalization?
Not during this hospitalization, but a previous one.
Previous one, okay. And does your patient meet 2 or more of the non-cancer hospice guidelines? For instance, do they have severe heart failure, lung disease, liver disease, kidney disease?
Liver disease, yes.
Okay. Does your patient have intractable ascites,
No.
jaundice?
No.
Does your patient have hepatic encephalopathy?
No.
Okay. Is their kidney function normal?
Primary of the primary cancer, liver cancer.
Okay.
Kidney function is normal.
Okay. So then we'll select no. And then what's your best guess for your patient's 1-year mortality risk?
What are the options?
Less than 17, 17 to 48, or greater than 49?
Greater than 49.
Okay. Now we'll press calculate risk. And looking at 1 year.
Final answer is
1 year mortality. Your patient's total score was a 17, and that puts them at very high risk for 1 year mortality. So you are correct in estimating a greater than 49% mortality at 1 year.
Mm-hmm.
And then you can actually print the report and find out a little bit about the validation of the instrument. And you can do that all online at ePrognosis.
Great. eprognosis.org.
Mm-hmm.
Okay. So tell me about any other tools that you know that are available to assist with prognostic awareness. I know there's a question called the surprise question. Maybe you'd like to review that for our nurses, or the palliative performance scale.
Absolutely. So the surprise question, so there are great, the caring criteria being a good one, and there are other even far better instruments. But they require a lot of detailed information, as you could tell even from the simple exchange that Regina and I just had. One very basic question is, would I be surprised if this patient died in the next year? And that simple question is shown to have incredible predictability in terms of survivorship. Mm-hmm. And so if you're finding that your answer to would I be surprised is no, and this is a patient that we should start this process, start thinking about, start asking about what's important to you, what are you hoping for, what are you worried about, ensuring that they have a medical decision maker, ensuring that they have advanced directives documented, making sure that their pain is being assessed and addressed in an appropriate way.
Mm-hmm.
As far as the palliative performance scale, what we do know is that function is very important. We know that function is a very reliable predictor. In many prognostic indices, you see function as being part of that scale. We didn't include it in the caring criteria for a simple and unfortunate reason, which was that when we reviewed those 800 charts, we did not find function documented. And we know that's a shortcoming in healthcare in general. And so I think that's something that we're recognizing as a very important predictor, and we are all getting better as healthcare professionals in documenting and addressing and assessing performance. Mm-hmm. But function is incredibly important, and so the palliative performance scale is just one example of a functional status. Are patients getting up and out of bed? Are they up and out of bed part of the time, most of the time, all of the time? Are they doing normal work, hobbies? Are they actually able to go out and work outside the home? Mm-hmm. All those kinds of questions are part of that assessment of performance, and we know that that's a really important predictor. And as a clinician, it's one of the most important things that I base my own functional assessment or my own prognostic estimates on patients' performance.
You know, and as we've talked about in the past, mobility is so key right now. We know in the hospital that if a patient isn't mobile, they're probably going to have an increased length of stay and might end up with an increase in 30-day readmission. So functionality is so key.
It's really important, and when we think about other more advanced therapies, one thing that we know is that if functional status is poor, many of those therapies are not helpful and in fact are actually harmful. As opposed to when function is good, people have much better outcomes.
Well, really, I want to say thanks for taking the time from your very busy schedule to be here with me today to talk a little bit about prognostication. I want to ask if you had any final thoughts, anything that you'd like to share with our students, and I appreciate you all for tuning in.
Yeah, no, it's always a pleasure. I've loved being live in person and virtually with your classes. I think my final thought is just to remember, we think a lot about hope in palliative care, and I just would want to drive the point home that false hope isn't hope, and that we have to be honest and give our patients empathetic and gentle information, but make sure that it's based in reality and truth, and to keep that as a sort of a final guiding principle.
Thanks. And
Thank you.
And I want to say I appreciate Stacy's time. She and I have collaborated on a number of projects, and it's great to have her as a physician colleague with me today here. Thank you.
Thank you.